So Amy and I will kick off this final session by telling you something about two ways we use MRI as a research tool at Barts and across the UCLP network. So the first question we ask ourselves when using MR is what added value does it actually bring to the table over and above all these different approaches to look at the disease. So the history you give us, examination, pathology, epidemiology, and blood and spinal fluid tests. And over the last 25 to 30 years, it has become apparent that MRI is particularly sensitive to multiple sclerosis, more so than any of these different approaches. And that applies particularly to two situations. One is the diagnostic scenario or diagnostic process, or early on in the disease, and the second is to monitor the disease course, particularly when treatment decisions are to be made. And we'll give you an example each as we go along. So the first one is trying to make the diagnosis quicker and more accurate. Many of you may remember this gentleman, Ian McDonald, sadly passed away in 2006. He was responsible for the installation of the first dedicated MRI scanner dedicated to MS research at Queen Square about 30 years ago. And his name is sort of the headline for the currently used criteria to diagnose MS. And the key points here are that to be suggestive of MS, lesions have to be disseminated in time and space. That's one. And the other is that any sort of potential other explanation has to be ruled out. So reiterating now in the year 2015 that MS remains essentially a diagnosis by exclusion. So what does dissemination in space mean? Now here you have four different scans. This is what we call infratentorial or in the cerebellum. So you see a little lesion here. So that's one location. Here are the ventricles. Here, so around the ventricle are called periventricular. Here towards the surface of the brain you find this, the lesions close to the surface or juxtacortical. And they also affect the spinal cord. No news for many of you. So as soon as you fulfill two of these locations or have lesions in two of these locations, you fulfill criterion for dissemination in space. Now, dissemination in time can be inferred from a scan that was done at the first or baseline time point already, when there is a mix of lesions that enhance after contrast injection of the contrast medium, and many of you will have had that, and you have at the same time contrast enhancing and non-enhancing lesions. Now that is the less common case. Most of the time you have to do a second scan at least 30 days later, and then what you can see is what happened here. There was no lesion on this in this location, but there is one now there. So they've got dissemination in time and space, which all then were listed up and sort of funneled into a set of diagnostic criteria who not only for you may look a bit confusing, but sometimes in clinic as well. So they can be a bit clumsy and not always perfectly accurate. And therefore, we were planning or doing a kind of a reappraisal of these of diagnostic criteria using a different approach. So instead of looking at the pattern in space and time, we've gone back to the lab and looked at the histology of MS lesions. And this is a section stained for myelin. Everything that's blue contains myelin, and where there's white, there's demyelination. And within the white area of demyelination, you see two blood vessels, and these blood vessels, they contain blood, and the blood contains hemoglobin, and hemoglobin, you've got iron, and the iron can be used for imaging of the veins because you have the blood in the veins. So this is one way of doing this in a collaboration with colleagues at the NIH. This is a so-called vein scan using a technique called T2 star. You see these little dark strips and dots. These represent veins. When you combine that with the lesion scan that we've done for donkey years, on the right side here for you, you come up with what can be called flare star. So you can see that there's a lesion clearly with a dark area in the middle, and that represents a vein, at least we believe so. And here there's a dot doing the same, and here as well. So in our group, it's Mark Mikkel and Tom Campion and a colleague called Paul Smith, who didn't send me a picture, so I left him with a label, who developed this further, so-called central vein sign. Here's a few more examples. These are from our work. And this is what they've so far come up with. They detected about 340 lesions, about 14 per patient. And what is important there is that the proportion of those lesions that actually had this dark area in the middle, the central vein sign, was nearly 90%. Now, from earlier work using a very strong, powerful magnet, 7 Tesla magnet, we know that once you hit about 40 or 45%, then that is a very strong suggestion for MS. Talking about a single time point, so looking at only one scan, only 3 out of these 25 fulfilled the McDowell criteria because they had at the same time gadolinium enhancing and non-enhancing lesions. So that means not only could this technique be more accurate and sort of remove the diagnostic process a little bit from the exclusion diagnosis, but also it could be earlier and cheaper because you only need one scan instead of 2 to make the diagnosis. So at this point, I think I'm going to hand over to Amy, and there you go.
Thank you. Okay, so I would just like to talk to you a little bit about what my PhD thesis is on. And what the goal here is to basically detect changes in the brain and the spinal cord better than we can actually go and see in the clinic by recording symptoms and or examinations. So, I work with T2, and T2 is a magnetic property of tissue in the body. All of your tissues have different T2 values, and so say if you had fat, that would have a T2, it's just a high T2 value, or you had muscle, it would be a low T2 value. But in the brain, we can actually group the tissues together, and they come together in these 3 groups here, with different T2 values. So up here we have a long cerebrospinal fluid T2 group, and then here we have a much shorter intra-extracellular water, that's the water in and around your cells. And here, this is the important bit, we have the myelin, the water associated with myelin in its own group. And if I go and take the T2 values I've found in my scans and I put them all together and only use those particular T2 values, what I can do is I can create a map of the myelin, or we believe to be the myelin. So here's your normal standard scan, and you can see here this is the white matter and the grey matter around all the outside here, and this is the myelin water map. And here in the white matter, we know there's more myelin. We see that there's much. Here we have this pattern of myelin in the white matter. Now, if you just take a look at those 3 lesions we have here, you can see that this one is quite large, but over here you can see that we have this dropout, and that's where the myelin has disappeared. But it's smaller than this area, and that's probably because of edema or water collection. So we could say that this might be an active lesion. Here we have an old inactive lesion, nothing much happening with it, and it's the same size in the dropout of the signal of the myelin map where there's no myelin. And here, this lesion, quite interesting, I can see that there may be some signal regained there, so that may mean that we're able to monitor be remyelination in these lesions. Ooh, right. Okay, so what does that mean to you, apart from the fact that we might be able to get a quantitative map of the myelin in a demyelinating disease? So that's quite good. Okay, so here we have curves. So I can take a sample. So whilst you're on your drugs, we're monitoring your drugs, you're on a clinical trial, I can take a sample of the myelin water fraction. So this is in percentages, 3%. And obviously it's much lower in the lesion. But if it comes back to this curve here, we can say that we've got a normal appearing white matter. It's remyelinated. Okay, so here's what I actually do. So I do it in the spinal cord, and I have been left post-mortem spinal cords by some very kind people who've given it to the MS Tissue Bank at Imperial. And they have left me these spinal cords, and I can put them in my MRI scanner and rescan them over and over again. So I can check my sequences and see whether the sequences I'm making up actually work. So a little bit of anatomy. Here we have back. There's the spinal cord and the brain. And up here in the neck section, if we go and take it and slice it like a salami, we've got a cross-section here. And you can see that this is the grey matter with the white matter surrounding it. And you get different patterns at different, wherever you go and take your different slice. So I first of all put this in my MRI scanner. And I took some images, and I made, after a lot of computing processing, I made some Myelin Maps. Now, in order to make sure that what I was looking at was actually true and real, I gave them to my histopathologists, Natalia and Daniele, thank you very much, and they actually went and sliced it just like a salami, and they took these slices and they put them under a microscope and they stained them for myelin. So brown is where the myelin is, white is where the myelin is not. And you can see we have signal here where there's myelin, and we have no signal here where there is not myelin. And this does seem to be have some sort of relationship. This is really new, only done a few months ago. But we believe that this has some sort of relationship. It seems to be quite proportional. So here, this is a really severe lesion. You can almost see that it's almost nothing there, absolutely black. This is a slightly less severe lesion when you actually look at it under a microscope. We can see that we still have some signal. So it might be possible to actually say, or make some quantitative measure of how much myelin there is left, whether you're on the clinical trial, whether your drugs are working, whether we're seeing any remyelination in your disease progress. And that is me. And I'd like to thank Tobias Wood and Gareth Barker at King's as well for their help with this.
So this is now the last slide, and it's a great opportunity to thank those who are actually funding this work, including the Royal College of Radiologists. The MS Tissue Bank has been very supportive, and Barts Charity for giving us a strategic grant to pursue this work, and obviously the whole bunch that you've seen already here on the right side. Thank you very much for your attention. Well, in this specific case, it was kind of natural cause, or it can only be natural cause because there was no treatment involved. We know that remyelination obviously occurs particularly early in the course of the disease in a considerable number of lesions, but that the potential for that goes down over time. So that's why it makes a lot of sense to work on facilitating that. Well, what Amy showed, that is completely without dye. Yes, but the first proportion of the talk, that included a contrast agent.